Well, good morning, members, officers and guests. Welcome to the Health Scrutiny Committee on this Thursday, the 22nd of the 22nd of the 2nd, 2022, all the twos. Apparently this is very rare and any of us here today won't ever see this happen again in our lifetime. So we'll make the most of it and sign as much as we can today on that date. So let's go to the minutes of the last meeting. Everybody agree with those? Anybody have any issues on them? No? Right, thank you. Before we move on, I would like to thank Councillor Matt Barney for all his work and help with this committee since May. I really did appreciate his help. He was a huge supporter of this committee and of myself. So I would like to thank him very, very much for the work he did. And I'm sure we'll all miss him, but we can welcome Councillor Nigel Turner, who is joining us today. So thank you for that. Have we any apologies for absence, please?
Yes, we do. We've apologies from Councillors Martin and Wilmot, who are on other council business, and Councillor Shaw is substituting for Councillor Wilmot. We also have an apology from Councillor Steve Carr for medical illness reasons. Thank you.
Thank you, Noel. Do we have any declarations of interest by members and officers, please? Disposable pecuniary first.
Chair.
Yes?
My daughter's training to be a nurse, isn't she?
Right, yes, that's fine.
Thank you.
I think you and I give one each time, don't we?
Yeah.
And I will give one because my daughter works at Queen's Medical. Do we have any private interests, please? No? So, fine. Now, we should at this point be moving on to an introduction to Health Watch, because we have a janter who used to join us has moved on. And again, I'd like it noting that we thank her. But we have a new lady who is chair of the Health Watch in Nottingham and Nottinghamshire, and she is Sarah Collis. I've had a little meeting with her just to get to know her. She was due here this morning. She is not as yet here. So we're going to move on to the mental health service review, and we do have those guests with us this morning, although a slight change because the lady who should be here has a problem with her car. We all know that, but if it hasn't been washed away in these floods, then we won't worry too much. So we have with us, and you're going to have to correct me if I'm wrong, Chris Ashwell, yes, good morning, and Rebecca Keating, good morning, and Gary Eves, good morning. Welcome to you all. You are going to take us through a briefing. We shall listen intently, and then we shall ask probably a few questions of you afterwards. So welcome. Go ahead when you're ready.
Okay, good morning everyone. So I want to take you through this briefing that we've sent to you. This speaks to the investment in mental health services through the long-term plan, and really sort of highlights the investment that's going in to mental health services and our ambitions for the future of mental health in Nottinghamshire and what that looks like. So in the serious mental illness pathway, which is a large part of the pathway of people accessing secondary mental health services anyway, there's been £12 million invested over 3 years up to 23-24. So this will cover things like psychosis and depression, IPS services, which is helping people get back to work, early intervention for people showing early signs of psychosis, personality disorder, and adult eating disorders. Some of those services have traditionally been quite small, I guess, in investment terms, and have struggled to cope with the increase in demand that we see in society these days for these services. So that's all the investment that's gone in, and we are working frantically as a provider and with the CCG and in the system to implement these changes. So lots and lots of recruitment into these posts, lots of alternative roles, so we're not relying on nurses and doctors and psychologists, OTs, lots of alternatives around that. We have had pressures around recruitment. It's probably one of our biggest risks in terms of implementing this plan, recruiting the right number of people to sort of for the delivery. And of course, then we have all the training needs on top of that, and that's sort of, we work with Health Education England to develop training programs to ensure that actually what we are delivering is evidence-based, that we are delivering psychological therapies that have some evidence base to them. And that's a key component actually of the long-term plan and the ambition. So as we move more into the world of ICS, rather than just talking about Notts Healthcare as a provider or the CCG, we're working as a system, and we'll be looking to roll out lots of these programs through the place-based partnerships, what was previously called ICP. So working more at a local level with all the system partners, working on delivery models and addressing areas of key need, inequalities, all of that kind of stuff. So I talked about the issues around recruitment and what a challenge that is. What we've seen with this investment is much more use and procurement of the voluntary community sector. So we're growing that all of the time and using people like Mind and Turning Point and Framework and Harmless, all of the local groups to help us deliver this ambition and not always rely on a secondary mental health services service. So the plan for access to mental health services to go from 2,315, which you'll see on your paper, to 7,000. So extra people accessing services. This is, a real growth in access, and not just growth in access, but a improvement in what's being delivered through evidence-based care. We're doing lots of work with the primary care networks to make sure that that care for mental health is joined up, and people are not falling through the gaps. We've currently recruited 10 mental health practitioners. These are generally qualified nurses, for the most part, senior nurses, working in primary care, joint funded, 50% from primary care, 50% through Notts Healthcare. And they're working around that pathway to help people in the local communities sometimes avoid being referred to more secondary services, so they might not have to see a psychiatrist, but they can be managed in primary care. But certainly to manage the risk and flow between the two, to keep things safer and ensure that people are getting the right kind of service and care. And we actually have plans to grow that even more over the next year or two to increase the number of people working in that way. In addition to all of that, we have invested and recruited in things like drug and alcohol services, lots of alternative roles, so people with lived experience, all sort of trying to cover all the bases, I guess, for what the demand is for mental health services, and so it's a little bit more seamless. In addition to the £12 million, there's 7.4 million invested in mental health through things like common mental health, so the services that you often refer to as IAPS, which is improving access to psychological therapies. So this is not serious mental illness, but more common, what they call common mental disorder. So often anxiety and depression at a mild to moderate level. And the access for that is increased substantially over the period of this investment plan. So in terms of our future plans, I talked about the integrated care boards and working with them to deliver services around personality disorder, developing the hub, adult eating disorders, and longer term community rehabilitation pathways. So sometimes people with sort of chronic, intractable mental health issues, you know, will be in a rehab unit. What we want to do is introduce much more in the community to enable them to live in the community and, you know, with their family or carers, and not always rely on inpatient care. Of course, that's still there, should it be needed. In terms of waiting times, our current waits are around 7 weeks. Now, against current national targets, the current national target is around 18 weeks. So we're doing quite well against that at 7 weeks, but it's actually not good enough. The ambition is to get an average wait to around 4 weeks for assessment. So that will be part of our plan and part of our performance, and one of our metrics that we'll be judging ourselves against to show that we are not only improving access, but getting people the correct assessment and care in a speedy manner. We've invested substantially across crisis services in both children and young people and adults. So we now have a 24-hour, 7-day-a-week crisis line that people can self-refer to. They don't have to go to a doctor to be referred to that. They can just call and speak to someone on that line. We've advertised it quite sort of a lot within local health and in communities, and now we've got a programme of having adverts for that on things like bus shelters and, you know, various places in the community to raise awareness of that. And that has been a great success. Demand has certainly grown. You know, the activity has grown around that, and that's a good thing because it means that people in a mental health crisis are calling to someone and speaking to someone. We've got a bit of work to do around the architecture of that. I think like the phone system and you know, software that we use is not perfect, so we're trying to improve on that so people get the best kind of sort of care and response that they can. Perinatal mental health, we have investment totaling 1.2 million. So again, that's to grow that community aspect of perinatal care in the community. And we've actually secured a further 375,000 funding to pilot a new maternal mental health service. So you can see through all areas of mental health speciality, this funding starting to come through and recruitment starting to happen and access starting to broaden. For children and young people, across the ICS, there's an additional minimum actually of 8 million investment up to 23-24, and this provides access to mental health support to around 8,500 children. So again, a growing area, and we can speak to that in more detail. I think one of the successes has been the mental health teams going into schools. That's grown across the county, and actually nationally now there's some more funding being released to increase that to 50% from 25%. So that's another good news story for children and young people, because we all know and hear about the needs for that. Into CAM's sort of community, actually we do quite well in terms of access to that for assessment anyway, but demand is growing, and we know we need further investment, and we've got more further investment into that to ensure that that access improves, that the waits reduce, and again the correct level of care is delivered. So that's the sort of précis of the paper, a bit more than a précis, bit of detail in there, but yeah, we're happy to answer any questions.
Well, thank you very much for that. Just before I open it up, there's just one or two questions I'd like to ask of you, which perhaps you might be able to answer. You mentioned the Voluntary Community Centre. Where is it? How many are there throughout the county? And what are you offering there? Are you offering social skills? So if you could answer that. And the other thing is, you've been given a fair amount of money. My question is, how can we ensure that it's going to get to the right place and not be just wasted by being put elsewhere? And I would like to know, to me, it's a big, big matter to discuss, mental health. There's no doubt about it. But to me, there's been an added sprig to the tree, and that has been the pandemic, because all kinds of things have happened since the pandemic arose. My concern is the effect on young children, young people, the adults of normal middle age who probably had meetings with their friends and lunch parties, and that was all stopped. And then you look at the elderly who have been absolutely trapped in their home. And I know of one person who still daren't go out because she had to shield. So how are these people being dealt with? Out of your 12 million, what are you going to be doing for these people? Because these are, in effect, new mental health problems. And you mentioned that you have adverts on bus shelters. I would question, I don't know, because fortunately I can say I haven't got that problem. But if you had that problem, are you really going to a bus shelter and reading something on a bus shelter? Are the GPs aware of what you're doing? Are the hospitals aware of what you're doing? And have you got posters up in all these places? Because I would have thought the first place for somebody who was feeling a bit stressed, anxious, whatever, would be the doctor. Rather, they might have to catch a bus to get there. But how are you really, my question is, how are you really going to make sure this money gets filtered off to the right people?
I can take the last question there, and perhaps the pandemic question with relation to children specifically. I'm Gary Eves. I'm the head of Mental Health, Learning Disability and Children's Commissioning for the CCG locally. In terms of the communications about the investment in services, we've just agreed with the County Council to expand the Not Alone website. Members may be aware of the Not Alone website that was launched last November, which was around promoting awareness of mental health conditions for children and young people and the services that are available locally there. We produced that alongside children and young people, so that was a dedicated website, and what we were wanting to do is grow that to incorporate access to adult services and awareness of self-help, where to access support, and almost the directory of local services there. So that's something that we will be taking forward this coming financial year, having secured funding to support that. I know that kind of, as well as Chris mentioning the bus shelters, etc., that we have had quite a comprehensive campaign around the new services, particularly the crisis services in the settings that you described, so hospital, GPs. We've also kind of recognised, partly linked to the COVID impact there, that actually kind of promoting these services in the COVID vaccination centres is a kind of key kind of area for people that are coming forward there as well. So we've increased that over the recent months, particularly kind of following the onset of Omicron. So we've recognised that that's a kind of a key area to look at there. In terms of the impact of the pandemic, and I'll talk kind of about children and young people, and Rebecca might want to kind of to share some views of that as well. We are aware that the impact is being seen in terms of referrals. Some of the evidence is still emergent, but actually kind of the increase in referrals, the increase in providers reporting increased acuity or complexity of cases. We've seen a specific increase in children and young people with eating disorders coming forward there, which whilst we had plans around the investment there, that's exceeded the kind of modelling that we had around the anticipated demand there. So we have had some challenges in waiting times for children and young people's eating disorders, particularly there. So they are kind of things that we're very cognizant of in terms of where we go forward with that. The investment in services for children and young people, Chris mentioned that there's a minimum of £8 million that we're investing by the end of the long-term plan period, which is March 24 at that point. But we have invested over £7 million this year. So we front-loaded the investment in children's services, recognising the historical challenges that we've had, but also the increased demand that we've had coming through. Not sure if you want to add anything.
Hi, I'm Rebecca Keating. I'm a clinical director for CAMS at Nottinghamshire Healthcare and the Perinatal Services and Adult Eating Disorders. I guess along with what Gary had mentioned about the impact that we've seen for young people due to COVID, we've seen the increases with young people with eating disorders, as mentioned, and also with young people presenting with psychosis. As Gary had mentioned, we've also seen an increase in acuity, and so we were able to launch early our 24/7 CAMS crisis offer. So we, as well as having 24/7 crisis care for adults within Nottinghamshire, in November 2019, we had a pilot to launch that as a 24/7 service for children and young people. And that was growing from the existing service, which was extended hours. With the impact of COVID kind of starting to happen before the pilot had ended, both the Trust and the CCG saw that the need was there. And so we've been able to continue that service from there. And there's also been significant investment to grow. So we will have hospital-based liaison services for children and young people presenting with acute mental health needs within our acute hospitals within Nottinghamshire. And we have 24/7 access for young people in the community who might be experiencing a mental health crisis as well. So I think those are the places where we've really tried to target getting the money to the right place so that it's meeting the highest level of need. As Gary had mentioned, with the eating disorders, we already knew that was a growing need. We knew that additional investment was needed there. So what we're having to do as a system is look at actually what are the changing pictures telling us, what were our initial plans, and what might we need to tweak in the short term to make sure that we are kind of meeting the needs that are coming through as effectively as possible, recognising that things do change and we do need to adapt and change with them. I know that you'd mentioned the voluntary care settings, and I think Chris was alluding to voluntary care services, so working with various different organisations alongside the Trust and working in partnership rather than just having NHS-loaded services as well. I'm not sure.
Yeah, so it is the voluntary care sector, sorry, not centre across Nottinghamshire. So all of the organisations that I mentioned, and hundreds of thousands of pounds actually of investment has gone into them to work in collaboration. These groups are often actually at the centre of the communities and realising what the sort of pinch points are around access, where the need is, and we do rely on them as well. I mean, they have centres all across the county. They have their own bases, but they also have workers who work into our local community mental health teams in quite an integrated way. You talked about older people. We're currently working to try and bring in more of the voluntary groups who work with older people, like Help the Aged, to try and understand a bit more of that need, because that is a concern to us actually. We know that a lot of older people don't access mental health services. So there is, as you say, a lot of unmet need there. We're trying to find ways to access that. I mean, I mentioned the bus shelters, and obviously we do the basics around spreading the message to the right people, but those kind of messages in communities do help, because they do get those people who don't ordinarily go to the doctor and ask for a referral to services, things like bus shelters, in hairdressers, community centres. It all helps to spread the message, and that's what we are trying to do.
Okay, thank you. I'm sure we've got other questions, and then I'll come back with one more. Councillor Adams.
Thank you. Good morning, everyone. Just a few things really. You discussed the Not Alone website. I just wondered, with the advancement in the NHS apps, specifically recently during the pandemic, and the way that you can manage specifically things like, repeat prescriptions, quite simply, or, stuff that you can basically do with a click of a button. I wondered, having had discussions with people who have been through the mental health process, whether there was any plans to add the progress of their own case, whether that be, we're now, for example, you've rang up, you've then, it sort of ties into another point as well. You then go, you've had your assessment, and how long before treatment? Because this is a bit of a key gap, I think, I understand in a number of services, is how that assessment then leads to treatment. And I wondered if, because not knowing that can cause an anxiety in people, if having that information at the touch of a button to know where they are in a queue would be incredibly useful to help them with that. So that's the first thing. And the other thing I wanted to ask was around the MHST that you mentioned as well in schools. I wondered, how does that actually materialise? Is there a counsellor effectively on site, or is there a group that gets called in if there's an issue specifically? Because it occurred to me that wouldn't be something that necessarily be active constantly. It would be more on a referral case basis from the school, I would imagine. But again, I don't know, so it'd be good to know that as well. Thank you very much.
Okay. I guess in response to the query about the mental health support teams, each team has, I think, schools within it which total up to about 8,000 pupils. And there's a combination. So part of the remit of the teams is about a whole schools approach. So the teams will join assemblies, they'll do work with teachers about how to embed positive emotional understanding, positive emotional well-being within the school. They will also offer groups to young people, they offer groups to parents, and they do kind of individual work with young people as well. So each school that's open to the MHSTs will have kind of a nominated team that they can contact and refer through, and they can also refer through the CAMS single point of access, so that they've got a range of different opportunities and options depending on the level of need for each young person within the MHST schools. Also, just really quickly, again, I know that there's been quite a few discussions about kind of how we advertise, and again about the apps. One of the things, particularly for young people, that we hear is that they don't go to the GP for issues. They'll either talk to their friends or they'll look on the internet and social media. So one of the things that we're developing quite strongly within CAMS is, in partnership with some of our young people and our young volunteers who have been through the service, is things like Instagram pages and Twitter feeds, and so that we're able to use messages from young people to help get the message out, to destigmatise and let people know where to come for help. And I'll pass back to Chris for the last bit.
Yeah, so in terms of apps and the sort of digital platforms, I think it's a mixed bag across various services. Rebecca talked about CAMS, where they do quite well with it. I think services like iApt, a lot of which is online therapy with direct, if not an app, it would often be a link to your care and treatment, for updates and offline communication, that kind of thing. But I think we certainly need to do some work on the app side of things in terms of keeping people in touch. We do have some sort of platforms that give information to people, that to sort of, while they're not actively engaging in therapy, there's lots of information on, it's called Recap, that we use a system called Recap in Notts Healthcare. But no, I think the app development is not one of our strongest points currently, and needs developing.
Just thank you very much for that, and just to sort of a comeback to another point that you made around obviously the Instagram pages that they use. Is part of that in any way an active response to what can exist on Instagram and can exist in how can I put this, helping people deteriorate rather than improve? There is we all are aware of these accounts that go out there and seek out vulnerable people, and especially in specific circumstances, and try and lead them down a path. Just interested to know if there is anything active that almost works as a a counteract to that that's out looking for these accounts and attempting to resolve that threat to people. You know, you do hear about these awful cases where children specifically have been bullied or in certain groups, and they end up in this you know, I can't imagine the awful world they're in at the time, to lead them to where they end up. But yeah, I just wondered again if that was something that we actively seek out. Thank you.
At the moment, it's not something that we have the software to be able to actively seek out at a local level. I think one of the thoughts behind us having a better presence from a mental health perspective, so that if somebody is to search for a particular hashtag around mental health, instead of being flooded with a lot of the negative options, there's a lot of positive options there as well. But I absolutely think it's a national public health issue, well, an international public health issue that there does need to be more about. I know that different sites say that they have kind of different buttons available for people of any ages to push if they feel that content isn't helpful, but I don't think that's enough.
Thank you. Councillor Welsh.
Hi, thank you. Firstly, thank you for your presentation. It was really informative, I felt. I've got a couple of questions. The first one is with regards to perinatal mental health. Firstly, I just want to say how great I think it is that you're extending the care from 12 to 24 months, and that someone has actually listened and taken heed of what has been said. And I think that's absolutely fantastic, because a lot of the mums that have had babies during the lockdown, the mental health situation is actually developing now, and they're questioning whether actually it's related to having a baby, whether it's lockdown and having a baby and not being with their families. So I just really, really welcome that. And I would really welcome some information as to how women can access that support and what that support actually looks like. Because for some women that are part of a group that I'm involved with, they don't necessarily need like the CBT or anything like that. They just need someone to talk to and some kind of reassurance as to where they are. So that kind of light touch mental health support as well. So I'd be really interested to know what that support looks like and how it's going to be delivered and how it's going to be rolled out, and also perhaps how we can get it out to our people in our ward as well, to let women know that this support is here. Because the other thing that I've found is women have had babies during lockdown, they've not gone to the usual groups and mothers and toddlers, so they're now at a point where they're quite isolated and they're just merging into the real world. And if you've got a mental health problem and you've not necessarily had all those other mothers necessarily to talk to, this is where it's becoming a bigger problem. A lot of women, I think, are suffering in silence over it, to be quite honest. It's just accepting it as a way of life and what happens. So that's the first thing that I'd be interested in. The other thing with regards to children and young people, firstly, I really welcome the 8 million in additional investment. You wouldn't, and there's certainly a massive need out there, and it's a huge challenge, I know, for people working in schools as well. And again, it's very different levels. I think you spoke about the complexities that are involved now. There are more complex cases in schools where some of that pastoral care in schools, actually it's beyond then being able to deal with it. So I do welcome that 8 million investment, and I do welcome the increase from 25% to 50%. My first point is, and you'll be able to, this isn't a criticism, it is a question. Why can't we get to 100%? What are those stumbling blocks to get to 100%? How do those schools get chosen as to where they have the support? Because my worry always is when you've got a figure of 50%, there becomes a bit of a lottery of support of services. So some areas will get lots, which is fantastic, there's that need, and some areas don't get any at all, and that actually becomes a problem. That some kids in some areas, and us as all local members, we always want the best for our own area, but here collectively we want the best across Nottinghamshire. So what is it that's stopping us from getting it to every single school in Nottinghamshire? And what can we do in order to get some of that long-term support that stays within school? So years ago, when I did work in education, one of the things that we've worked with health is training school staff So training that pastoral teams that are there in secondary schools, training those ones perhaps that do special educational needs on some of those basic but core elements of identifying those mental health issues, when they should refer, when they shouldn't, having that core person or a core team of people within every school. Now, if we could do that across Nottinghamshire and get that into 100% of schools, how fantastic would that be? I mean, and that should be the ultimate goal, shouldn't it? Because what we're saying is the pandemic has caused mental health issues in children and young people. Nationally, I think the statistic in 2017 was 1 in 9 from 5 to 15-year-olds. Now it's 1 in 6. That's a huge difference. I don't know what the figures are here in Nottinghamshire, but there has to be something, I feel, that goes in schools for children and young people that carries on. You know, and the 8 million investment is absolutely fantastic, but what happens when that goes? So if we've got people in schools that are trained and there, and I just wondered whether that was an option, whether that was something that had been floated with regards to health, and also what's preventing it getting from the 100% to the 50%, and how those schools chosen. And then just a couple of things just to clear up for me, because I think you mentioned it in the eating disorders element, which you said there was an increase. A couple of people within my ward have said that the criteria for how they're referred to CAMHS has changed with regards to eating disorders. Now, could I get some clarity on that, whether that's the case or not, and whether the hold up with regards to eating disorders is now resolved, and what the length is of that waiting time, and whether there has been any criteria change to CAMHS at all recently, and what are the actual waiting times at the moment, and I think that is all of my questions, and I apologise if that's a lot, but yeah, all of my questions, I think. Thank you.
Right, I'll have a crack at those, Councillor Webb. Starting with perinatal, we absolutely recognise that actually this is a real positive development. We were quite fortunate in Nottingham and Nottinghamshire that we had a really well-established perinatal service ahead of most areas kind of nationally. And that's in some part to kind of our psychiatrist from old Margaret Oates, who we named the unit after there. So we've been fortunate that we've had that service in place ahead of time, but actually I think the growing recognition nationally kind of about extending the access to 24 months, increasing work around access to a psychological model within that service, but also recognising the needs of fathers and partners within that. So that's been very positive there. What's important to note is that it remains a secondary mental health service, so this is still for mothers with severe mental illness, still kind of at a secondary care level. So what within that kind of, I think some of the examples that you shared, we do have pathways in place between perinatal and IAPT services locally, because again, for many of those mums that you might have described at that stage, there might be more of a common mental disorder that needs to be supported that wouldn't necessarily be supported through the community specialist perinatal service because of the requirements there. I guess some of the areas that we have, the development of the maternal mental health service does to some extent lower the thresholds into that. So we are supporting those with more moderate needs at that level there as well. And that's kind of often for individuals that have suffered birth trauma, kind of birth loss potentially, kind of, but also who suffer tocophobia, other kind of conditions in terms of pre-conception support as well as kind of postnatally there. So I think they're definitely kind of areas of positive development there. My view is that we need to be doing a bit more work around promoting the changes in perinatal. And when we look at some of the access and some of the variation in access across different parts of the county, that's definitely something we need to be looking at, how we promote more in the Mansfield and Ashfield area, particularly there where we have lower levels of uptake of that support there. So I think there's definitely some work there. And from an inequalities perspective, the service has undertaken quite a bit of work to review the differences in who's attending and who's not. So kind of what the equity of that provision is, and that learning will kind of take us forward in terms of the comms plan that needs to come out of that going forward. When we look at children and young people, you mentioned the pastoral support and the role of schools within that. So obviously the mental health support teams are in addition to what is already in schools there. I think what's worth noting is that as part of the wellbeing for education recovery work from the Department of Education that's come down to local authorities, particularly through the educational psychology routes there. The mental health support teams and CAMS have been working really closely with those kind of as part of the steering group that's in place. So kind of particularly looking at what the increasing need is for children in school. That is where the work around the Not Alone website came from. So again, working with schools about what children were saying they needed, what was missing and how we provided that information. But equally, the other aspect of that is that steering group has put a consortium bid together across the city and the county to deliver approved senior mental health lead training in schools. So you may be aware that schools now have a requirement to have a senior mental health lead, and through that work there, that will kind of strengthen the training and the knowledge within schools, and that senior lead within school has then a responsibility alongside the mental health support teams to embed that mental health approach across the school setting there. So again, that's a positive there. In terms of the question about why not 100%, the mental health support teams are still a national pilot. So as part of the long-term plan, the commitment was to pilot that service within 25% of the school population across the country. Because the early signs of that are positive, nationally they've extended the funding to increase that to 50%, but it's still being piloted, and that's why there's not a commitment at this stage for the 100%. Funding is in place through to 2023-24 to support those, at which point it's expected that that money will be part of ICS baseline budget, so we can kind of continue those beyond March 24, and hopefully kind of additional funding to expand that beyond, so we do have that 100%. How we identified the areas, we have had a look at what the levels of needs are, kind of when we've looked at referral numbers, etc. So we have in the phasing, particularly the early sites, we've looked in those areas with kind of the most complex needs with the highest referral numbers, and that's kind of how we've prioritised that investment. There has been an opt-in from schools to be part of kind of that process, but we've not had an issue with that. So that has been a real kind of positive reinforcement of kind of the need and the kind of willingness for schools to work with us there. I think when we look at the kind of future rollout, we're also testing, particularly in the Broxtowe area, work around the most vulnerable children, so kind of looked after children, etc. Kind of, so we're doing some targeted work to test the model in a different way about how we can target more vulnerable young people at that stage there. What I would state around kind of a lot of the kind of increasing demand generally is that actually the children and young people operate as part of a wider network. So we have to be mindful of wider decisions that are taken around other children's services and changes to those, and that might be around children's centres or youth services, and the impact that that will have, because those protective factors and that kind of early intervention support there, that has changed over a number of years. So we are seeing kind of, whereas historically CAMS would often be the last port of call for support, quite often they're now the first port of call. So there are kind of changes across the system that we need to kind of understand. When we look at the health and wellbeing outcomes for children and people, only 15% is contributed or attributed to the health services that they access. So 85% is the wider system around them at that stage there. So we have to kind of understand that CAMS are obviously an important part of the system, but actually the mental health and well-being of children and young people kind of is kind of bigger than just the services that we're talking there. So we have to look at that. In terms of the children and young people's eating disorder demand, we did modelling last year when we looked at kind of the additional investment, and we looked at historical kind of referral patterns and numbers of referrals, particularly at that stage, and we modelled that on what the data was telling us at that stage there. We've had over 13 13 out of the 15 previous months, a sustained increase of referrals there. And what we've been trying to understand is that a temporary impact of the pandemic, or is that the new norm that we need to be planning for? And through work that we've been undertaking with NHS England regionally and the clinical network that we're part of there, we've been informed that we need to be planning that is the new normal. But that now requires us to kind of identify additional investment to what we've already agreed and kind of to what the service has started to recruit to with that additional investment. So there is a gap there. The national standards around eating disorders are that we have two. So the standards around urgent care is around, correct me if I'm wrong, so 95% are seen within 1 week of urgent care referrals, and for routine referrals, 95% are seen within the 4 weeks there. Our performance currently for the routine is 81% of referrals are seen within the 4 weeks, and 66% are seen within 1 week for urgent referrals. Now, what's important to note within that, the numbers are very, very low. So actually the percentages can be 1 or 2 referrals a month that will take us below the target at that stage there. Previously, kind of the reason for us not achieving that target used to be because the parental choice or the child's choice to not have the meeting at the initial assessment at that point. Now that has more recently been about capacity within the service because of the increased referral. In terms of the question about thresholds changing, though, I'll leave that to Rebecca.
Hi, so I can confirm that our thresholds for the CAMHS eating disorder hasn't changed. The threshold for the service is around an identified eating disorder, so it would need to be around a diagnosis of anorexia or bulimia, or there being significant markers for either one. I think one of the challenges that we do have is that we're a mental health commissioned service, so we don't currently have the commissioned remit of providing physical health care to these young people, and I think that's where we're having some difficult conversations with primary care at times, because they do feel that it's quite a specialist area, so they can feel uncertain about managing the physical health of young people presenting with eating disorders. We do always do that in collaboration where they are open to the team, and we have a psychiatrist that can kind of help to advise around that, and nurses within the team that can do the same. I think although the team's remit hasn't changed, the presentations of many young people have. So we have the traditional classic eating disorder diagnoses, but what we see an awful lot of as well are young people with disordered eating who don't have an eating disorder, who wouldn't fulfill that criteria, but who, I guess, food and appetite and being able to eat is part of a wider psychological difficulty. And so those are young people that we often work with within kind of our community teams or other teams within the service as well.
Thank you. Are you content with those answers? Do you want to come back? No? Yeah.
And with regards to, you say they have to be diagnosed first. No, you didn't say that, sorry.
No, it has to be diagnosable. So on the referral information, they ask specific queries around kind of cognitions around body image, what their BMI levels are, what the weight loss kind of has been like.
Thank you. Councillor Shaw.
Thank you, Chair. Thank you. Can I welcome this particular update? I'm picking up on what Chris spoke about earlier in his narrative, the pressures around recruitment and the delivery of the plan. And it's concerns that we've got literally hundreds of people in Nottingham that are facing dangerously long waits for health treatment and support in what others are calling a second pandemic, fueled by a surge in mental health conditions such as depression, anxiety, psychosis, eating disorders. Also, loneliness and isolation are key factors and drivers in this. I think we're moving now to a new phase and having to live with the coronavirus, and having to got people that are really, really worried about what the future holds. And the virus is leaving a growing legacy of poor mental health, and that services are not equipped to deal adequately with that at the present, given the enormity of the situation that we've just gone through and still perhaps to go through. Concerns around waiting times. I've looked at page 14, top of page 14. Current waiting times across the community teams are around 7 weeks, but the national average or national ambition, it says, is to move to four weeks by the end of 2023-24. Given what Chris said earlier, is that doable because of the length of time it actually takes people to actually train up and become familiar with the client group that they're going to specialise in? Also, would you agree that there are hundreds of people in Nottingham that are facing a longer wait than need to be due to the lack of staff shortages? Given that your budget's only 12 million over 3 years, if you broke that down, it's £4 million per year. And given that the length of time it does take to recruit, train, how are you going to re-establish contact with those people that have fallen through the net and that may well think that all they've got is the four walls around them and nothing else? And how can we be consistent with contact with someone who may be in crisis if we haven't got enough qualified staff to go and see them? So you establish contact with a CPN perhaps on a regular basis, and that person goes to that person in crisis, and then 6 weeks later somebody else goes, and you're starting the whole story again. If you see where I'm going with this. And given that £12 million over 3 years is due to end in 2023-24, and Gary, picking up what Gary he said, that it's a self-help and support. I'm just really concerned that a 4-week pilot, what that's going to look like, and how confident are we going to be able to hit the 4-week target by the end of 23-24. And my final question is that of the services that are provided throughout the county, and that also includes the city, how is that broken down in as a percentage of what services are likely to be funded throughout the county area? And is the city draining most of that resource of that £12 million? Because it's often been said, and I've worked in services where we thought the county there's nothing in the county, all the funding and the services are in the city, and it's city-centric. Thank you, Chair.
Okay, so in terms of allocation of funding, actually no, we have done it on fair share basis, so we don't prioritise city. In fact, when we've implemented these changes, we've started the sort of projects in round mid-knots rather than in the city. So we do that. In terms of the 4-week wait, there is definitely a pressure on recruitment. And of course, a compounding factor is our own workforce. You know, we have people with stress and mental health problems due to COVID, and COVID absences as well, which we are trying to manage all the time. In addition to outbreaks, in a lot of our community services and inpatient services when we have to close them down. So it is a challenge, but we need to try and meet that challenge and meet the 4-week wait, I think. And I think, the stuff I touched on earlier around increasing use of voluntary sector and others, not just the qualified nurses, psychologists, doctors, etc., will help us towards that. And we are certainly working towards that in our planning and trajectories. But we have to acknowledge it as a challenge.
Just to add to that around the funding, the NHS long-term plan goes through to March 2024, and obviously we have very prescriptive levels of investment, and that in part is because I think NHS England nationally recognise that where money has come down to mental health services before, it's never been ring-fenced in the way that it is now. So kind of whilst there's been that ambition to invest in mental health services, that's not always translated at a local level. So we do have very prescribed kind of areas of perinatal mental health, serious mental illness, children, young people, etc., to make sure that the money's going where it's required at that stage there. And there is commitment nationally that the investment will be made recurrent as part of the baseline budgets for the systems going forward. So that money should be kind of secured. And that's what we're planning on. So none of the areas that we're investing in are on a temporary basis. They're all on a permanent kind of basis on that stage there. I guess the variation in historical spending across the different areas to some extent recognises that until a couple of years ago we had 6 clinical commissioning groups. That's now 2. But what we have found is that there was variation in that spend. So kind of part of the additional investment is around the equity and making sure that the money is going where the need is, and kind of making sure that areas that might not have had that investment historically are brought up to that kind of level as well. There. So that's a commitment that I can share, that's how we have looked at how that money is spent where it is needed going forward to address any gaps that we have.
Yeah, and just for clarity, sorry, when we talk about 12 million, etc., this is additional funding on top of our core mental health budget. We have a standard now, a national standard. It's the mental health investment standard, which ensures core mental health funding and that money going to delivery of mental health services for the people who need it. Thank you.
Thank you very much. Councillor Bailey.
Thank you very much. I actually had 2 questions relating to challenges of the plan. One of which you've almost very much addressed in terms of waiting times, where you said recruitment was the big factor. So I suppose as a whole, you also said it was just recruitment was a factor in the entire plan. I suppose the question is, have you got any other challenges that haven't been raised in the report, but you fear that could run the risk of not meeting the targets? Thank you.
Yeah, I mean, Councillor Shaw touched on the pandemic, and I think that is always a risk. I think it has, in addition to recruitment, it has hampered us in our progress in what we're trying to achieve. In terms of delivering safe care in our community basis, for instance, we had to close lots down at one point, and then we had to do work to ensure that, we had social distancing and the right kind of, safety measures in place there. So I think any continuation of that is a real challenge for us. In terms of the waits, we do have programs like Waiting Well, where we try and keep in touch with people who are waiting, so that they're not completely left alone, and we do provide resources to support that, which I touched on earlier. So I think the pandemic is a big risk for us, and just maintaining that momentum. I guess one of the big challenges, we're working across different sectors with primary care, with secondary mental health, with local authority often, with third sector. It's keeping that momentum going, because as well as doing all this transformation that we're talking about, we are trying to keep our sort of core businesses safe and operate as we've been doing for a while, and transform and change at the same time. So that is, a risk for us really, is engaging our workforce and everyone in that change process and keeping the momentum.
Thank you. Councillor Turner.
Thank you, Chair. I think myself and many others in the room recognise the great work that third sector organisations do throughout the county. I led a third sector organisation previously for 16 years, and I understand the work that third sector can bring to these issues. However, I believe there are many third sector organisations, community groups, centres that go under the radar. What are you doing about identifying these organisations?
Who's going to answer that one?
We've obviously identified a range of key mental health specialist providers that Chris has identified. In addition, we have funded social prescribing link workers. So again, identifying early kind of those individuals that are starting to kind of struggle for various reasons, and look at how, through social prescribing, we identify existing local voluntary sector organisations that might be a walking group or a kind of, a men and sheds group is an example there. So kind of how we can identify some of those. I think there is a significant challenge there that actually when we've put capacity into identify that need, but actually a priority over this coming year is to review kind of the sustainability of that sector to identify those. And we are working with the CVS organisations across the city and county to look at how we work in partnership to understand what the opportunities but also what the risks are. The city CVS recently undertook a state of the sector review, and that's been repeated across Newark and Sherwood and Mansfield and Ashfield. CVS is there, and many of those organisations have identified that demand has increased, but their funding, they've had to either stop aspects of their service or in the next 12 months are anticipating that they'll have to wind down altogether there. So that's a big risk that we need to kind of look at there. But we have identified some funding to support engagement with the smaller voluntary groups and community groups at that point there to identify how we can do that, working through the CVSs to enable that. Thank you.
Thank you. I'd like to come back actually with another question. Firstly, I appreciate exactly what you as a team are trying to do in what is, I'm sure, extremely difficult circumstances, not least that you can't recruit people very easily, and I can fully appreciate all that. When we started last May, many people had mentioned, would we look at mental health? And I said, of course, and that was that. But in the interim time, as I explained before, there's a little branch on that tree that has changed, and it is the people who have suffered from the pandemic, because it has definitely left a legacy, a very unwelcome legacy. Now, I have a concern that if an elderly lady or a middle-aged lady, or for that matter, children and young teenagers, go to primary care, which is probably their first port of call, without saying that they do and assuming that they do, I dare say the GP could possibly say, well, I think you need to be referred to the mental health team. Now, if that happened to me, it would send awful alarm bells to me that all of a sudden I had got mental health problems. So obviously some people have, many people have, much more serious than probably an older lady going to the doctor because she says, I'm feeling stressed, I'm feeling anxious. But that doesn't mean necessarily that she goes into the mental health numbers. So it concerns me, and certainly with children, if they go for eating disorders, that they're all of a sudden told that they will go and see the mental health team. Because it puts, whether you like it or not, a stigma and a name to a very young person, which they will carry for the rest of their life, that they've had to go to a mental health team. So what I'm wondering, you've obviously got two things here. You've got the people who suffer from mental health very seriously, and I have been into a mental health hospital, so I have seen it. But you also have these people who are suffering with a bit of depression, a bit of stress, a bit of anxiety. So my question is, if the GP says, I think the mental health team ought to have a word with you, to avoid sending alarm bells to those people who've probably been locked away for 2 years and are feeling very stressful at just the thought of going out, is there a way that you could say that they might go to the health and well-being team, which is associated to mental health, but not actually saying they're going to a mental health team? Do you see where I'm coming from? So that they don't feel, by going to the doctor, that they're automatically being told they've got a mental health problem, because I think that will deter people from going. Because they're fearful of, particularly if they're older people, they're fearful of what might happen to them along the line. And I wonder if there's a way of saying that there's a mental health and well-being team who can help you rather than just a straight, I mean, it may be a stupid question to ask, but I'm looking at it from the point of people who, an elderly lady of probably 65 who's been sitting in her house in a block of flats for 2 years, and all of a sudden she wants to go out and she goes to the doctor because she's feeling a little bit strange, and she gets told she's being sent to the mental health team. I mean, it's enough to send her over the top. So how can you sort of alter that name for those sort of people that are truly not mental health people, but they've got a slight mental problem from the very fact that the depression or stress or anxiety, whatever you want to call it. Am I right or am I wrong that it could be, children particularly could be labelled with that?
I give a personal view here, and my clinical colleagues might have a different view to here, but I guess the conversations that we're having about mental health and addressing the issues of stigma, I think having those open conversations are important, but acknowledging where people are starting from and their experiences and some of those negative connotations, that's what we're trying to kind of overcome kind of with that. I guess it's about understanding that all of us have mental health. And actually, you know, depression and anxiety is a diagnosable mental illness as well. So a bit of depression, it is a mental kind of disorder. That might be at a kind of a more mild end, but I think that's important for us to kind of be encouraging those open conversations of all generations there. I guess some of the work that we've done, particularly for those that don't require a secondary mental health service, but if we look at IAPT as an example for the common mental disorders there, which might be kind of moderate, mild to moderate anxiety, depression, kind of relationship kind of pressures, those types of things there. We've been doing some specific work around how we, at different target groups, so young adults, so kind of those aged 18 to 25, how do we support those individuals, but also kind of increasing the numbers of people accessing that are over 65 is a national target there. So we've been doing some particular work with Age UK around how we can be working in a more sensitive way with opening those conversations with different communities that haven't historically accessed but actually would benefit from accessing those services. So that might be about softening some of the language or kind of making it more appropriate to the audience at that point there, while still that underlying thread of challenging some of the stigma that kind of, so it is okay that actually if you have a UTI and you go to your GP, that's as okay as going to see a counsellor to talk about how you're feeling at that point or might be struggling kind of there. I'm not sure if colleagues have a different view there.
I would like to, I guess, come in on a very similar vein really, and I think there's been an awful lot of work nationally around reducing the stigma around mental health, particularly for young people, and with young people's access to social media and various platforms. I don't feel there is as much stigma around mental health in young people. I think that's a double-edged sword. I think sometimes it can almost be glamorized to have mental health difficulties for some young people, which isn't the way that I would want things to go. But I would absolutely do the same. I see mental health in an equal way as physical health, and we all have a continuum of physical health where we have days where we might be really well and fit and healthy, days where we might have an illness or we might have a broken bone. Mental health is the same. We all have days where we might be on good form. We have days where we all struggle for different reasons and in different ways. So I think for me, it's about really destigmatizing that with as many people as we can. And for me, that feels really important across the board.
Yeah, I think that is really important that they realise that they're on a path and they will recover rather than having the feeling that that's final. I think that's very important with the more older people who've probably been stuck into a flat somewhere and they all of a sudden feel that they're not only being lonely, it's given them mental health problems, you know, and that's something I've got a concern about. Okay, has anybody else got any questions? Councillor McGrath.
Thank you, Chair. I've only got a few. Just a quick, first of all, Chris, I'd like to thank you. It was that doctor lady who got back to me concerning my friend when he came in November. Thank you very much for that, mate. One, do we use radio as a means? Right, just, local radio, as the chair's pointed out, a lot of old people do prefer the radio to watching Coronation Street and everything else that they put on. The other one is there a link between certain types of eating disorder, because obviously I'm not an expert, and the increased use of food banks? Right, that's another question, which I think you touched on earlier. Right, the other one, throughout the funding, right, and I think we talked about it before, do we help the prison officers and office ladies, right, and that link there? Because sometimes when you go there, have they got, the ability to deal with the people that they both get in prison and the police cells? The crisis centres as well, are they geographically round the county, and whereabouts are they? And the last one is that councillor there, sorry I don't know his name because I'm new, right, pointed out the funding for the groups. Like, there's loads of groups across that take a lot of the older folk all over the county or all over the country. As you pointed out, sir, as well, have we looked into that to get them out of, hopefully, which is going to take a long time, to get them out there again as summer's coming up? How do they apply for this, and how do they get in touch with anyone? Thank you.
Okay, in terms of the radio, I'm pretty sure we've already put some adverts out on radio around mental health services, and if we haven't, they're going out. I'm pretty sure of that. The crisis teams are across the county, so we have them in Worksop, in Mansfield, in various places in Nottingham. So they're across the county. Just remind me of the questions. The engaging with older people sort of socially, I probably think that is more of maybe a local authority responsibility.
You said you were looking into about the funding there. On the days out. Sorry.
Part of our social prescribing work, we do need to be looking at kind of that, but actually that it is also about working with social care colleagues and so on there, and public health colleagues, because when we look at loneliness, I think there was a loneliness and isolation kind of being deemed a significant issue. There are matters of public mental health there as well, so we work closely with the public health colleagues in both the county and city councils there. So I think they're the kind of areas where we would pick that up, but that's a partnership and a system kind of thing that we need to look at as well there, to make sure that people are getting support before they need services.
On the prisons, so this funding wouldn't go directly to prison healthcare to help with this, but we do have funded prison mental health care. So within the prison, there will be a wing, I guess, where it's for people with mental health problems, and they have, psychiatric doctors and nurses helping with that. And then really it's in the planning. So there is a process for when someone is being discharged under the Mental Health Act, that they're connected up with services locally. So if someone's discharged from prison and has mental health issues, then that collaboration should be in place with prison and local services. So we know that they're coming out, we know what the needs are, and we can plan effectively around that.
Oh, is that all right?
And the eating disorder, food bank.
We don't see a link in that way, but one of the things that we have seen a link through is the number of young people that we see in CAM services that are in poverty. One of the things through the pandemic that we've done a lot of is working to increase options of offering kind of video consultations for young people, but we've seen some young people that haven't been able to access that because of digital poverty, because they don't have the devices to be able to do that. So again, I think probably more on a public health platform, that is something that we've seen a rise in poverty throughout our children and young people's mental health services, but not necessarily in direct correlation with our young people with eating disorders.
Okay, thank you. Well, thank you to all three of you. We are asked to consider the information that's been provided to us, which I think we can safely say we've done. And clearly, we're not at the end of this by any stretch of the imagination. We're only at the beginning of it all. Could I just ask the committee if they have any thoughts on when we have these three good people back again to come and talk to us, what you'd like more information on, or what you would like more clarification on? Does anybody have anything that we could particularly... Councillor Bosch.
I'd be interested to know which schools and where. And I'd also be interested to know a bit more about numbers. And I know it's not all about numbers, but I would be interested in, one, the link with regards to poverty, the children in poverty and the mental health. I think that's really important. But also the numbers with regards to the perinatal mental health as well, and where they are, whether there's a link with regards to poverty or I don't know if you're monitoring that at all. If there's any link with regards to that as well, would be quite interesting. But where, and I suppose for all of us, even for the county, where is it more, where is it happening more, or where is it happening less, if that makes sense? And is it quite stark? For example, what we've seen in the disadvantaged areas, it's huge, and in the not, it's not, and why that is.
Thank you, Councillor Wells. Councillor Turner.
Back to the same theme, really, third sector organisations, and I think we need to look at how we strengthen that, and the development within third sector organisations. You mentioned Mind, you mentioned Harmless, but there are a lot of smaller organisations that are doing some great work, and working with these organisations, I think, will improve the situation overall.
Councillor Shaw, I think you've got a request.
Thank you. Yeah. I'd just like to think that you'd, in the future, look at the percentage of service take-up in Ashfield, Mansfield, and as a breakdown for the whole of the budget. I'd like to see what uptake we've got in Ashfield and what could be improved to actually improve the uptake, especially with the people that are isolated. Thank you, Chair.
Thank you. And I think from the chair, I'd like to see a breakdown of what you're doing in the areas, in all the district council areas or the ward areas, or however you can do it best. And let's see the money that you're putting into that area, and possibly the amount of people that you're serving in that area. Not unhealthy people, not healthy people. The people who you're actually trying to provide for in that area, so we have some idea of breakdown of cost of what is being spent and how many people you're having to spend it on. I'd like to see that, please. And also, I'm still concerned about these age groups and some update on the senior people you're seeing, the middle-aged people, to put it mildly, and the more younger people. Some breakdown of that. Yes, Councillor Bailey.
Thank you. I also have a request in terms of updates on where we started, where we currently are when you provide your next update, and the target so in particular the waiting times. So where we currently are now, where we'll be when you give the update, and obviously the 4-week target. And the same thing with recruitment. So where we currently are with staffing, where we were, which is today, where we'll be at the next update, and what you estimate is the staffing figure that we'll need to actually hit those targets.
So with that, we've given you a little food for thought, and I've just consulted with Martin here, and I think he will be in touch with you with a view to probably returning late summer. Yes. Is that all right with all of you? Many, many thanks for your briefing. It's been very useful, and I think it leaves us with thoughts of where to go from here. So thank you very much to all three of you.
Thank you.
Don't need the live stream off, do we?
No.
Thank you. Thank you very much, and thank you for inviting us. So what I was going to do, you've had our briefing, which is dated January, so hopefully we're going to be able to, as well as taking questions, give you some updates, situational updates. So I was just going to cover the context in which we've made temporary service changes, how we make those decisions, and provide an update on some of the decisions that we have shared with you. So just very briefly to go through the context. As you'll recall, back in March 2020, the NHS was put into a level 4 national incident, and we got very clear directive guidance from NHS England to step down a range of planned care and community services so that our sickest patients could be treated and cared for in hospital. And as the severity of the impacts of the Delta wave of COVID reduced over the summer of last year, the NHS was able to move back to a more business as usual rhythm, where we started to restore and recover planned care services and primary care services, as well as dealing with COVID patients in hospital. November 21, we returned to a level 4 incident as the Omicron variant escalated, and in December NHS England wrote to us to advise us that we had to take a number of actions to respond to the Omicron variant, which included a significant increase in our vaccination capability and capacity, and also rolling out antiviral medication treatment. And again, this was predicated on a sense that we would need to firstly protect our population as much as we could through proactive immunisation or antiviral treatment, and also be sure that there was capacity in hospital to treat sick patients, but also to try and keep doing as much of the planned and routine care as we possibly could. And at the time, obviously, the situation was emerging in terms of the severity of Omicron. Significantly, I think in the context of the paper that we've shared with you, just before Christmas, whilst we had some very clear directives about vaccination and antivirals, there were no national directives about how to create capacity. So we had no specific advice about what services we should and shouldn't step down. And it was very clear from NHS England that they wanted local systems to make their own decisions based on their own local pressures. We have what the paper provides you is a list of the decisions that we made over the Christmas period, but also the approach that we've taken to ensure that when we have to make changes like this in the interests of public protection, all the factors affecting changes in services are considered in the round. We take an interdisciplinary approach so that individual providers don't make decisions in the absence of understanding the options that there may be for other organisations or part of the system to sustain provision of care. So we've shared the decision-making process with you, and we're happy to talk to you about that should you require us to. So we are, as you will obviously know, whilst we still have patients in hospital with Omicron, we are coming out of the severity of the Omicron wave, and we have recorded and reviewed any decisions about temporary service change that we made through our governance processes. That is the list we've provided with you. Lisa is going to provide you with an update of where we are in terms of reinstating the services. So there will be no permanent service changes as a consequence of the temporary changes we had to make. So she's going to provide you a general update, and also we understand you wanted to understand decisions taken by the ambulance service in relation to home births. So we'll provide you an update on that. And then finally, I will just follow on with a description of the situation on Sconce Ward at Newark, if that's okay. So I'm going to hand over to Lisa, who will update on the temporary service changes shared with you.
Okay.
Thank you, Lucy.
Afternoon, everybody. So in regard to the service changes that you had appended to the paper, I'll come back to EMAS, but the suspension of home birth, that incident has been closed, and so that is no longer the current situation in regard to that. That closed on the 1st of February. In regard to Sherwood Forest, the changes that they made by moving some of their 8 bed spaces moved the discharge lounge to Clinic 6. This was all part of their operational management to manage what we described as super surge related to the management of their incident. That's now closed and that's now been rectified as of the 4th of February. In regard to Sherwood Forest, the 10 spaces where they had to repurpose their cardiac catheter lab to an emergency ward. That did mean for a very short period there were some longer waits, but now that has all been put back, and that situation is now closed as of the 4th of February. NUH, as you will be aware, had to close Harvey 2 elective ward to accept some urgent admissions, and this was connected. They at the same time put some extra provision in other wards in order to maintain their cancer and urgent capacity as best as possible. That at the end of January, they, after undertaking a deep clean, that ward began to reopen to elective patients again. So that has now resolved. In regard to city care, the continuing care team had to step down parts of the service to release staff to support community nursing. There was redeployment of some staff, and that was stood down as of, and those changes began at the end of January. On the 25th of January, it commenced. And NHT had to undertake ongoing review of staffing issues during the surge during winter, and significant pressures with staff absence due to Omicron. And they had a review of the nationally suggested areas to release capacity in line with our national direction, but that has now also closed as an incident. Going back to the EMAS issue, and we're happy to take more questions on this. Many apologies that EMAS weren't able to attend today due to annual leave. But Greg Cox, the Divisional Director, and their Director of Communications have provided me with a form of words to update you that I can read out if that's helpful. So towards the latter part of December 21 and early in January, EMAS, like other providers, experienced significant staff resource pressures due to the COVID-19 Omicron variant, generating additional medical staff to stand down and staff sickness. This was reported appropriately in the EMAS Trust Board meeting papers. EMAS at that point took the appropriate decision to alert system partners that the timeliness of responses to 999 emergency calls could be adversely affected by those shortfalls. Stakeholders also will recall the briefing sent at that point confirming that the military would be joining EMAS on a short-term basis to support with the delivery of urgent care during that challenging period. EMAS can confirm that staff resourcing has now improved and is now at a level that will likely support timely responses to 999 emergency and urgent calls. So that's the EMAS statement. So in summary, the EMAS alerted providers and alerted the relevant stakeholders. The providers undertook their own risk assessment and stood down home births as a result of that, and no doubt compounded by staffing pressures as well. So that's the EMAS position specifically.
Thank you. Thank you, Chair. If it might be easier, because there's a number of different changes there, if people have got any questions on them, and if I finish with Newark, is that okay?
Yes, that's fine. Thank you. Councillor Welsh.
Hi, can I ask a question with regards to the suspension of home births and how that happened? We've spoken certainly before with regards to some of the work that I do with people that had babies or are pregnant now as part of a group I organise. Home births appeared to be cancelled pretty much overnight a lot of people found out via social media, via Facebook, rather than any contact before. I mean, the post is still there on Facebook for you to see, and the people commenting below that. So one, is that the usual way that you would communicate with women with regards to the cancellation? Like I say, it's still up there for you to see. It's in the public domain that people are supposed to be having home births within the next few weeks were found out via social media. So I would like to firstly say, is that the usual communication strategy with regards to the suspension of home births? I understand it actually quite quickly came back on again. And subsequently, again, a lot of people found out that via social media. I have nothing wrong with social media communicating, by the way. I think it's a really effective way to get messages out there. But I think sometimes when you have, no, I think definitely when you have a birth plan or you have a specific thing, it would have been really useful to have different amount of contact and a more clarity of information as to what is going on. Now, the suspension happened pretty quickly, which I'm assuming, and you can correct me if you're wrong, that was because there were staff shortages within the maternity departments at NUH and QMC, which we'll talk about a little bit as well, because it's also my understanding there was a period of time over a weekend where women were being sent elsewhere from the QMC and from the City Hospital to elsewhere in Leicester and Derby to have their babies because you didn't have the capacity in QMC and NUH, and that wasn't actually that long ago. And some people were left with the conundrum of actually how to get there as well, didn't know how they were going to get to Leicester or Derby. And all these things happen with a lack of communication, and it wasn't, maybe you'll correct me if I'm wrong, from what I have been told, it wasn't handled particularly well for those women, which really disappoints me in the sense that the maternity departments are supposed to have this improvement plan, and actually what it was about is communication and how women are treated when they're in that vulnerable stage of being pregnant. So that's my first thing. With regards to home births, but moving on from there, with regards to the fact that we're now saying that it's taking place, are they actually taking place? This is a real straight question. Are they actually taking place? Or is the situation is you've reinstated it, but the chances are when you start your contractions and you phone up and you say you're due for a home birth, 9 out of 10 times, or 10 out of 10, or 8 out of 10 times, they turn around and say, well, we've got actually no one to do your home birth. You're going to have to come in. Because I've heard that on 2 occasions recently, that home births is reinstated, but then when they ring up, they've not got the capacity, which again reflects what's going on in the maternity departments at NUH, which we're all averse with here. And then my other question is then that relates to the safety of home births as well. So if there is an issue with regards to capacity in being able to do home births, I believe that home birth should be a choice, but only when it's safe to do so, which I'm sure you agree with as well. I'm sure women would rather know that they can't have a home birth, but they can have a safe birth within the hospital, than you feeling that you just have to put that there's home births, the availability. Does that make sense? That I think women would rather know you can't have a home birth because actually we can't guarantee that we're going to get the right staff to you. We haven't got the capacity to be able to do it. They would rather know that than electively put down on their birthing plan. Which birthing plans, I have to say, I don't know anyone that's birthing plan has ever gone to how it should be, because things always change, don't they? But I would like some clarity with regards to the home birth situation. So one is with regards to safety, because it's one of the things that I feel really passionately about, as many of you will know, about women and baby safety during birth, how you communicate to women when those changes take place, and how you communicate to women when they think they're going to have their baby at Nottingham City Hospital and they turn up and they're not going to have that baby at Nottingham City Hospital, and they've got to go sometimes to a city or a place that they've never been to before, never mind. I mean, I've travelled quite a lot, but I don't think I've ever been into a hospital in Derby or Leicester, for that matter. So, and it's different staff, and it's different case notes, and it's different work. So I would like some clarity with regards to that, because that might have been a very small service change over maybe a few days where they had to go, but it would have been useful for us to have that information, given our ongoing concerns with regards to maternity, which I know you'll understand. And then the other question is, just to make sure that I got it right, is with regards to city care, where you did say the continuing care team to step down. Has that reverted back, did you say?
Yes.
Could I just get some clarity? And I apologise, I don't know. What is the continuing care team? And how was it that we could take people from continuing care team to there? Was it robbing Peter to pay Paul as such? Like, how is it that we've got a team where we can take people away and put them there and then bring them back? What happened to that continuing care team when those staff were moved over? Because that's always a concern as well. And I'm sorry if that's a very low level question, but it is a concern that, you know, that you're taking it away from one team to put it in another team, and it doesn't. I don't understand it, so that's why I'm asking for the clarity.
Do you want to answer the CHC one or not?
Lucy,
Cover the maternity.
Lucy, before you answer that question, added to Councillor Welsh's question regarding home births, if it is so that they were transferred to other areas, what kind of timeline are we looking at that these people are given notification that they're not going to have their birth at home, but they might have to go to Leicester?
Yeah. So your questions are all absolutely things that I would like to answer. We might not have all the answers today, but I think we can, certainly if it's okay with Chairman, we will commit to give a written response to the things we can't respond to today. Absolutely. And I'll I'll cover the continuing healthcare. I'll give an outline of the maternity. Lisa might want to add, but if in terms of your specifics about how providers communicate, we would need to talk to them just to be sure we're giving you the right information. So continuing healthcare is the assessment of people with complex and ongoing needs. And it's quite a specific sort of assessment process. It's a specific skill set. And these are patients that will have continuing, ongoing, probably complicated healthcare needs that they are constantly reassessed, but they will have care plans, they will have support. But you're absolutely right. In times of crisis, and this was crisis, we do shift resources. So just to give you an analogy, in March 2020, we had a national directive to, for example, all school nursing, all health visiting, all audiology. We stood it all down. So that was a national directive that that those services should no longer be provided, so that those staff could be repurposed to support Omicron. So those are the kind of decisions that were taken with national guidance in wave 1. We didn't want to get back to there in wave 2, and that's what I was trying to explain. We didn't, it was potentially before Christmas, it looked very, very worrying. But the suggestion was make your local decisions about what services you can step back. And you're absolutely right. So we had to make risk assessed decisions about if we move resource from this service, there's a cohort of patients that won't get the service they might have got, but those staff can provide a different service. Continuing healthcare is one that it was assessed by CityCare, the provider, that they felt the patients requiring continuing healthcare needs assessment could be kept stable, but the staff could be temporarily redeployed to the more urgent. So you are absolutely right that yes, these decisions do have an impact, but we tried to make decisions that had the lowest possible impact. So that's the continuing healthcare question. And it was about, it was very much a balance this time, that we wanted to keep as much of our core services going, as well as dealing with thankfully, what turned out to be not such significant numbers of very sick patients as we'd had in the Delta variant. The maternity, your questions generally about maternity. If I just give you sort of an overview, I think you are, well, again, I couldn't disagree with you that women should have a right to choose a home birth, but only in the circumstances when that can be safely and effectively delivered. Lisa might be able to support you with that, but we can get more information. I do know in terms of the decisions, there will be some dates which we can come back to you, because we will have them recorded, because we have a sort of an emergency procedure when we don't think there is safe staffing for maternity, and decisions again have to be made potentially to divert women to other units. We can share that protocol with you, and we could also let you know exact dates when that might have happened, so we can come back to you on that. And the other thing I would say more generally is we wouldn't rely on social media to make, any communication should be personal. So, social media is a backup, but if something affects your care, you should be directly communicated by the midwife, in this case, in charge of your care. So the specifics about when there were diversions, we'll know for how long, how many women, to where, and on what dates. and we can share that detail with you.
Can you put your microphone on?
Sorry.
Councillor Welsh.
Yeah, I was just right. The communication with regards to home birth didn't happen as it did, as you're saying, to a number of women. So I'd really appreciate if you could take that back. And as I said, if you look on Not CCG Facebook page, it's quite clear the distress of some of those women that found out that on social media rather than being communicated. It is very clear that happened. Why or how, I'm not sure, but I would really appreciate it if that could be looked into, because again, it's the tried old thing that we spoke about, and Councillor Sue Saddington has spoke about on numerous occasions, about communicating with women and letting them know what is going on is vitally important. So it's not a criticism; it's feedback as to what actually did happen and how it can perhaps improve in the future.
By way of an update, and I mean, I'm completely with you on all of those questions, by the way, and that's sort of some of the nature of the discussion I had with some of our quality leads yesterday, in regard to the planning of home birth and how women might feel if they haven't really, planned to go to hospital. They need to prepare for that thought, don't they? They told me that they believed that for NUH, the community midwives contacted all women who had a booked home birth during the period and were due to give birth during that period, but they also put comms out on the Facebook page. Sherwood Forest, meanwhile, also wrote to all women that had booked a home birth due to give birth during that period. However, I suppose the question is whether they actually did manage to capture all women, because I think you're alluding to the fact that there may be some women who hadn't been notified, or whether the women who weren't due to give birth during that period, who might have wanted to plan ahead perhaps a little bit within the services. They also tell me that there is a daily review of staffing and a risk assessment at NUH in regard to the ability to continue a home birth service. Sherwood Forest is slightly different because they offer home births where women are likely to give birth during the day. Now, clearly, there is a time component of that because they have less staffing overnight, so there is less on-call availability. So that drives some of their risk assessment for women who can be able to give birth, depending on the timing of it. Now, women who are transferred and women who, after risk assessment, there is no availability of midwives, I think it is possible that is a later decision than we would anticipate, but I haven't got any details of that yet. I don't know to what extent women were notified on the day, for example, or women who wanted a home birth, they weren't able to have one at reasonably short notice. So I don't have detail on that, but they do a daily risk assessment, and they do, if they are short of staff, they aren't able to provide that service. And Sherwood Forest, the women know when they book that there is a likelihood that may not be available to them if they gave birth in the night because of the staffing levels that are available at night. But your points are really valid and well made. I think the social media thing, it is out there on social media, and they did emphasise that, but they did genuinely believe that they'd captured all women by writing to them during the period, of course, but it wouldn't capture women who, following a risk assessment, then they had a later decision to offer an alternative place of birth.
Thank you. Councillor Bailey.
Hi, just a quick one following up from what you just said. When you say you Sherwood Forest wrote to all women, could I just, was that via email or like paper copy? Because obviously one will be a lot quicker than the other.
I don't know, I'm afraid. Yes, well, you're right. I don't know whether they received a hard copy as well as an email. I would hope that they received a hard copy of a letter, but we can check.
Thank you for that. Any other questions? Councillor McGrath.
First of all, ladies, thank you for what you've done over the last whatever. But thank you very much. Just a quick one. Thank God we are coming out of Omicron or whatever the other variants we've had. Is the plans ahead? Because obviously the Prime Minister announced yesterday that it was 75 and over vulnerable people from 12 and upwards. Will you be doing it, or will it be down to the GPs again? Because obviously a lot of vulnerable people are still going to be afraid to come out, or will we as an NHS be going out either to care homes and this, that and the other to make sure that at least they have got that protection that they all want? Thank you.
So another excellent and very timely question, and of course we're then looking at the announcement about options for younger children. So we learn a huge amount through the vaccination programme about how best to offer vaccinations to people, and we've learned that there is a blended model is the best model. So some people in care homes, people who are housebound, you need to go to. GPs have different ways of doing it. So I think we will, and I'm not answering your question directly, but we'll continue to do what we did last time. We will always focus on the most vulnerable. If that means delivering the vaccinations in the home, whether it's by your GP or a dedicated vaccination team, we will do that. We know that COVID is going to become like other seasonal illnesses. I think it's going to become part of the fabric of the NHS, and clearly we want our general practitioners to be part of making sure that people optimise their uptake. But yeah, absolutely, people will not lose out for once being clinically vulnerable, housebound, or in a care home.
Thank you.
And we did, I think we learned a huge amount through this last couple of years, and I think we ended up with a blended model where it's unlikely that we'll see the mass vaccination sites in the way that we did. We hope that we can actually either deliver directly to people or in primary care.
Well, that's what I'm saying.
Yeah.
Doctor, is it doctor or nurse? Sorry, that's what I'm saying, because last time we tendered, I know it was we tended to wait until all of a sudden there had to be mass vaccinations, which, to be perfectly honest, caused a panic throughout the country, didn't it?
Yeah.
It wasn't your fault, but so that, again, if we could please, and then make it known.
Yeah.
I won't use social media myself, but make it known publicly.
Yeah.
So everybody's got at least that bit of confidence.
Yeah,
Thank you.
I think the more that we can do through our GPs and our networks of GPs, the better. But there'll also be people that need to be vaccinated at home or in care homes.
Thank you, Lucy. Councillor Shaw.
Just picking up on one point you've just made there about GPs, we are absolutely strapped for GPs in Hucknall. Can you give us any assurance when we're going to get the new Cavell Health Centre in the heart of Hucknall? And would you think that would be in the near future, or is it long term before that's going to happen? And also, would you say that the crisis within the Nottingham University hospitals on maternity care is in crisis, or do you think you've turned a corner on that?
So the development in Hucknall, all I can say is that it's absolutely top of our priority, not just to provide better facilities for general practice in Hucknall, and we recognise that, but also to make sure that we can provide other services to the residents of Hucknall to stop them having to go to hospital. I can't tell you at the moment. I would like to think it would be opening in the short to medium term, but there are sort of broader issues around that. But just to tell you, it's exactly the kind of thing, that sort of multidisciplinary provision of primary community and maybe even some services that used to be offered in hospital in your own communities. That's our direction of travel. So I know that's not answering your question specifically, but just to say we are committed to that development is probably the best I can tell you now. I can't give you exact timescales. Your question about NUH, there's a sort of set of improvement plans, and there is a process around that. We are very much working with them to get to the position where those issues are fully worked through. I think there's still a long way to go, but I think we are, I think, jointly across the health and care system very clear about the issues that we need to tackle. And we are absolutely committed to doing so. And it won't just be Nottingham University Hospitals alone, it will be all of the partners in Nottinghamshire to help remedy those issues.
Thank you, Lucy. Has anybody got any other questions?
If I just, it's okay, if I just finish on Hucknall. Yeah, on Newark, sorry, apologies, my mistake there. So we've sent you a separate paper on change to sconce ward at Newark Hospital. So sconce ward has 32 beds on it. I can assure you that there are no beds being closed, but the type of patients discharged into those beds has been modified to take account of, as the paper described, availability of particularly overnight medical cover. So what the paper describes is a temporary change that was made. It is a temporary change. It is under review. We will come back to you. Well, hopefully we'll be able to tell you that the temporary change has been reversed. If the conditions endure, then we'll come back to you. But effectively, it's 32 beds. Patients are discharged to them from Kingsmill, or indeed potentially repatriated from other hospitals, who are what's called medically safe for transfer. So these are patients who otherwise possibly could be at home, but there may be reasons for them not being able to get home because of social care and other support packages. So they are now treated on sconce ward. So they're slightly less acute and dependent patients than we may have had in a subacute rehabilitation ward. But those patients are getting excellent care, and as I say, there is no net loss of beds. We are hopeful that a solution will be had to provide the previous level of medical care as soon as possible, but at the moment that's not been remedied. So just say very much temporary service change, and one that we continue to review.
Thank you for that, Lucy. I know if any information hits Newark regarding Newark Hospital, the rumour always goes round that it's closing. So I think you have very carefully explained that it is a temporary change and not a permanent change, and you will guarantee that Newark Hospital as of now is not closing.
I will absolutely guarantee that Newark Hospital, as of now or as of any time in the foreseeable planning future, it is not closing.
That's
absolutely
fine.
not. No.
I just see the headlines in the Newark Advertiser.
Yeah.
It has happened so many times. So thank you very much for that. Does anybody else have any more questions? Well, I think we've done very well on that, Lucy. We've summed everything up quite well there. Thank you very much. I know with regard to our work programme members, next month, are we next month? Next month, we're going to be looking at tomorrow's NUH, if you have your paperwork together by then. But I appreciate it's a very large project.
No, we certainly do want to come and talk to you about it, because it is coming to the point now where we want to engage with the public to help them, to get them to help us shape our proposals. So as is appropriate, we would like to talk to you before we do that. So we are most certainly going to come and talk to you. You're right, it is a very broad programme of work, a significant investment for the good in health and care services in Nottingham, but one that we need to make sure that we engage, obviously, you as the public's representatives and the public themselves in shaping. So it's been, I know we've been talking about it for a long time, but we've got some sort of slightly more formed thoughts that we'd like to get your sense about. So we will be here next month.
So members, that's next month. Also, we're looking at, guess what? NUH maternity services again. So plenty of things there for food for thought.
Yeah.
Thank you very much, Lisa, and thank you very much, Lucy. And with that, members, unless I've forgotten something, I think that we finish the meeting today, which is a record. Thank you very much, everybody. Can we stop the live stream, Stuart, please?